Thank you very much. And yes, welcome for everybody that has come on this particular just before the long weekend. Normally our long weekends start lunchtime on the Thursday before Easter Friday. But I think what's amazing about tonight is just having the opportunity to actually create a CPD module that clinicians will be able to easily access to be able to also update themselves on this important field. I'm going to put my video off just to help us save a bit of bandwidth. And tonight I'm going to be specifically focusing on the HIV Clinician Society Gender Affirming Healthcare Guideline that came out in 2021. And I think with COVID and everything else happening, this guideline is not always that familiar to people. And we're going to talk specifically today about the key population of transgender and gender diverse people. So one of the questions I often get asked is about why is there a specific guideline just around providing care for transgender people? And I just want to have a slide specifically talking around key populations. So this guideline was one of the responses to the National Strategic Plan that said we need to be able to look after a variety of key populations. And just in terms of what we mean by key population, I'm sure some of you are aware of the Wheel of Power, and I always find this useful in terms of when we're thinking about our key populations. So the Wheel of Power shows in our societies of today who are those that carry more power, and is usually those with unearned privilege within a society, versus those that we typically call marginalized populations. And our key populations usually fall within these marginalized groups. And when we talk about intersectionality, we're talking about how the more of these particular unearned privileges you have or were born with or born into, the closer you are to the center of power and the more power you have in a society. The more you are sitting on the outside of this circle, the more one can say there's a combination of unearned disadvantages. And the more of these unearned disadvantages you have, the less power and the less challenges you might in a particular society. So just to give an idea, for example, if you are a cisgendered male, English speaking, if you're rich, if you own property, if you're slim, if you've got a robust mental health, if you're neurotypical, heterosexual, able-bodied, and have a post-secondary education, white race, even still in South Africa, and you're a citizen of this country, the more of these aspects you have, and that's many of us in this meeting today, the more power we have. Where if you are trans, intersex, or non-binary, if you're non-English speaking, if you're poor or homeless, if you're large in body size, more vulnerable in terms of your mental health, maybe have some neurodiversions, are lesbian, bi, pan, or asexual, have a disability or only elementary education, and the darker your skin is, the more challenges you will have. And I think the problem we have in communities and societies is that those in power, those sitting in the center here, are the ones that decides which varieties in our sort of vast amounts of different varieties that we have as human beings, what is considered acceptable, what gets privileges and power, and which ones do not. And being transgender, you can see, is sitting right here on the edge of this wheel. And as a key population, they've been identified as a population that is particularly vulnerable, both in terms of HIV infection, we're vulnerable in terms of mental health illnesses, and vulnerable in terms of substance abuse. And important to realize it's not trans that makes them vulnerable in terms of being transsexual, doesn't make you transgender, does not make you more likely to be vulnerable to, for example, mental illnesses, but it's a way that society is responding to the fact that you are transgender that causes the problem. And so it's this power that leads to all these systems of classification, marginalization, discrimination, and oppression that we're still seeing so much in the world of today. So the Retiche report, I'm sure many of you are aware, there's a whole group of NGOs and advocacy organizations in South Africa that every year specifically look at healthcare institutions. They do a large survey to try and see in terms of access for key and vulnerable populations within our healthcare facilities. And this is the report from February 2024, and this is the stats specifically focusing on our transgender and gender diverse people. And it says that only 35% of trans people found staff that were friendly when they were at the facilities. As much as 61% of trans people did not think that privacy was well respected. Only 7% of trans people felt very safe or comfortable at a facility. And 10% of trans people, very worryingly, have actually been denied access to their HIV treatment in the last year. And 72% of those trans people who are no longer accessing services in public health service facilities reporting staff being unfriendly as the main reason. So if you look at transgender people and some of the health challenges they face, the biggest reason is the fact that they're not accessing care. And one of the big challenges is because of us as healthcare providers and the kinds of services that we provide. So in the National Strategic Plan, and this is the latest one that's come out for HIV, TB, and STIs, in Goal 1, there's specifically a focus on reducing stigma and discrimination, and they include our key populations. And one of the small sub-goals is to enhance access to gender-affirming healthcare. The third goal is around building resilient systems for HIV and TB and STIs, and they've actually got a section on key populations. And under transgender people, they are specifically highlighting that we need to include gender-affirming packages of services at all levels of care, and that we need to have transgender-friendly facilities in all service settings. And you can see all of our, and that includes DOH, NGOs, higher education, etc., needs to be able to start implementing these recommendations. So these recommendations was already in the strategic plan of 27 to 2022. And as a response, there's been a variety of different guidelines that's come out for the different key populations. And the South African HIV Clinician Society specifically put together a gender-affirming healthcare for South Africa. What makes this quite an extraordinary healthcare guideline is the amazing involvement of a wide range of different cadres. So people from all kinds of different professions. You can see the team there. We have family physicians, we have infectious disease consultants, we have psychologists, we have speech therapists, we have social workers, and we have people from advocacy organizations. But also there was a very strong involvement of making sure that there was also trans representation within actually the creation of guidelines. And these guidelines have therefore been endorsed by a wide range of different NGOs that's been providing care to transgender populations in South Africa. So the scope and the purpose of the guideline is to provide evidence-informed best practice recommendations to enable South African healthcare providers, so that's all of us, including psychosocial and allied healthcare professionals, to offer quality, affirming services to our TGD clients. What I also found amazing about the guidelines, because you don't often see those in our normal sort of ARV guidelines, is that there's very specific values that's actually outlined at the beginning of the guideline. And we'll look quite a bit at affirmation this evening, but they specifically talk about dignity, equity, inclusion, informed consent, and looking at the ethical principles in healthcare and how they are relevant to this particular guideline. So I'm going to assume that we're starting a little bit from scratch. I find the young people are very aware of the language and the terminology, where those of us it's much been a bit more longer in the tooth still has to get to know and learn much of this language. And so we're going to go a little bit back to some of the basics. And you will see we talk about TGD people when we talk about this key population, which is referring to transgender and gender diverse people. So being able to talk about about gender, we have to be able to differentiate biological sex from gender. And biological sex is typically what we say, what the midwife will say when somebody is born. So there's this particular, is it a boy or is it a girl? And we have these characteristics of biological sex. So for example, that includes your chromosomes, whether you have ovaries or testicles, whether you make testosterone or estrogen, whether you've got breasts or beards. And then of course we have our intersex population, and you can see those differentiation of sexual development. As much as 1 in 1,000 and probably even more of our population would be considered intersex, which is as common as twins. And we now understand this. This is part of human variety. And how do we raise these children as having just having natural variety rather than putting it as a pathology or as a disorder. So gender identity, and I'm going to use the definition here from the Yogyakarta Human Rights Principles, who define it as each person's deeply felt internal and individual experience of gender, which may or may not correspond with the sex assigned at birth. So the midwife might go, oh, it's a boy when you are born, but those genitals do not necessarily identify the way or define the way you feel in terms of who you are. And identity is something we only become aware of as we grow up, as we grow older in our younger years. We suddenly have an experience of who we are. And that's usually not to do with what is actually happening within our genitals. So terminology, cisgender is when we're talking about gender identity and sex assigned at birth as being aligned, where transgender is when that gender identity is different than the sex assigned at birth. The term gender diverse refers to actually a whole wide range of different experiences. So the definition that we use is this is people who do not conform to society's or culture's expectations for men and women. So if you're cisgendered, so the webmaster said, oh, you're a girl at birth, and you've always been told that you're a girl, and your identity as a girl, this might not have been such a clear revelation. It's not like one day you wake up when you're 12 years old and go, oh, actually, yes, I do feel like a woman. And we take it a little bit for granted. But if you are transgender, or if some of these labels simply doesn't feel like they make sense to you, then you will start feeling this discordance between what you bodily are told that you are and the experience you have of yourself. We now understand that this is all very much biologically laid down. And when you look at, for example, how the prevalence of transgender people in our population, it's a fairly set incidence or prevalence across the world in different countries. There's a lot of countries where we don't have statistics, in countries where it's still illegal, but somewhere between 0.5 and 0.7% of the population identifies transgender if they are able and allowed to do so. So just to put it in context in terms of development, so our ovaries, our testes, our gonadal sex is laid down in the first trimester of pregnancy, but our prefrontal cortex and a lot of our neural networks of identity and personality is laid down in the second trimester. And it definitely has a large genetic component, about a 39% genetic component, but there is also hormonal and other influences that creates these neural networks. And as you grow older, you suddenly become aware of what your inner experience of yourself is. And we now therefore know from the neuroscience is that different forms of sexual orientation as well as gender identity are very much understood as variations of human diversity. And in a population where we have there's so many different possibilities, we know that ourselves, when you have 2 or 3 children in a family, how different they all are. And these are all different possibilities that can arise. So as medical profession, we've had to catch up because, of course, one of the challenges, a bit similar with homosexuality, is that homosexuality until 1973 was seen as a disorder in our DSMs, and until 1992 was still in the ICD-10 as a diagnosis. So similarly, we've had to depathologize being transgender. And the DSM-5 that came out in 2013 has changed gender identification disorder to the word gender dysphoria. The ICD-11 in 2018 changed the word gender identity disorder to gender incongruence. And so both of those terms explain this experience of, hold on, my experience of myself is different than my biological sex. And then the WHO in their assembly of the 25th of May in 2019 actually made a statement to say that trans or gender diverse persons does not mean to suffer a mental disorder. And what we have found is that this memo is not always filtered through. So there are still, and you can see this happened just before COVID, who still consider being transgender as a mental health disorder, even though it's very clear that it does not fall under our mental health classifications. One of the questions we often also get asked is why we are seeing so much, that word transgender is coming up in a variety of different scenarios. Why are you suddenly seeing transgender people within your facilities? Where's these terms like non-binary all of a sudden coming from? And the history of left-handedness helps to explain that a little bit. So up until 1939, it was unacceptable to be left-handed. Some of you, hopefully we're not all quite that old, but would have remembered those days when they used to tie children's hands behind their backs. If you would try to write with your left hand, you'd get smacked on the hand. And then it was realized within the early 40s that actually it's not appropriate and it's actually quite harmful to try and force a left-handed child to try and use their right hand as their primary hand. And that became more and more acceptable over the next 20, 30 years, both in education as well as in medicine. And so you can see by 1972, we now have about a steady 12 to 14% of our population is left-handed, and that is the neural networks have been laid down. And we are going to see a similar trend, and we're already seeing that with being transgender, as it is becoming acceptable, as these terms are out there to help define people, the experiences that they are having, we will find a larger number of people identifying as transgender or gender diverse. And you will start seeing people like that in your community, so staff, colleagues, and definitely also patients. So just to make the terms really, really clear, and also for when you actually have patients coming into your consulting rooms, for example, the important definition is that of what the identity is, what creates the term and the language. So if you identify as a transgender woman, then you were assigned male at birth. You identify as a woman, and we would use the pronoun she and her for her. If you're a transgender man, then you were assigned female at birth, identify as a man, and the pronouns that is correct to use would be he and him. And then there's various terms that people use, such as non-binary, gender fluid, genderqueer, agender. These are all terms that denotes gender diverse people. You can't decide what somebody's identity is. They will tell you, and they will explain to you what they mean by this. And this can be somebody of any biological sex. The gender identity does not necessarily fall into these traditional binary categories, and they use the old Shakespearean singular they, them. So they, them, we quite often use that as a gender neutral term when we're referring to somebody, for example, there's somebody at the door, please go and open for them, or please help the child with their shoes, they are struggling to tie them. So those are all terms that's already there, and we can use that when somebody does not want to be classified within the strict binary. So, for example, in a consulting room scenario, or in just in our OPDs, in our clinics, we need to be able to have a way on the file to be able to, we obviously need to be able to identify whether somebody was assigned male at birth or assigned female at birth. That's quite important from prevention. You know, are we doing PSAs, or are we doing cervical screenings, for example? But it's very important to be clear that this is a transgender woman and what pronouns they are using, or this is a transgender man and which pronouns that they are using, and very much important to use the correct name. So our files need to make it clear who this person is, so that we use the correct names when we, for example, call them out in the waiting room. Just a quick slide on gender expression. When you are looking at somebody, you can't decide what their gender identity is. Gender identity is not to do with what you wear or how you express yourself outwardly, but it has to do with an inner experience. And so gender expression can be completely independent from your gender identity, and you cannot guess or assume a person's gender identity simply at looking at them. This is Jonathan Von Ness. They are one of the Queer Eye presenters, and this is when they won their Emmy, and you can see they've got this lovely combination of the beard and the gorgeous shoes, and you can see there's this mixture of these different concepts of male and female. If you are unsure, simply ask somebody's pronouns, and if we respect the pronouns, we won't get this wrong. So a couple of more terms. Gender dysphoria is the term that we use to describe the psychological or physical distress caused by this incongruence between the sex assigned at birth and gender identity. And this is an important word to use when talking to our transgender patients to find out how severe gender dysphoria is for them. Not all TG persons experience gender dysphoria. It's very individual, and it can range from very mild to very severe. And this is the term that we still have available in our DSM-5 and our ICD-11, which is quite important for administrative purposes. So if you want to access HRT and surgery, for example, then you want to be able to have a code that you can put into that application. So when we talk about gender affirmation and use the term gender affirmation, this is an adjective that we use to refer to any behavior or intervention that affirms a transgender person's gender identity. And we take this so for granted. If you're a cisgender person and you identify as she, that people are, call you Mrs. when they address you, that they use she or her. And every time they do that, they're actually affirming the identity that you are presenting with. And for somebody who's transgender, where that's not always a given, this affirmation is very, very important. So the HIV Clinician Society guideline very clearly states that they support this notion of depathologization of TGD identities, and that we adopt an affirmative stance towards gender diversity. This gender affirming healthcare and all of these interventions, all of these gender affirming things that we can do has got extraordinary benefits, especially on the mental health outcomes of our TGD patients. So there's very good evidence on how it adds to quality of life, how it allows our TGD people to live more freely and authentically, how it decreases suicidality, and huge improvements on mental health and, for example, in depression and anxiety. So gender affirmation actually comprises of many different domains. And I think the most important message actually here is this talk is not about getting everybody to necessarily prescribe hormones. It will still probably happen in very select practices and with very select places, but every single facility is able to do social gender affirmation. And social gender affirmation is using the correct name, using the correct pronouns, and affirming and allowing people to be able to, for example, use the clothing that affirms their gender identity. So social affirmation, for example, in a school setting would be allowing that people can choose whether they want to wear the male or the female uniforms, for example. Psychological affirmation means having access to counseling and trans-competent mental health care. And there is now also more and more across the world. For example, it's being unethical to try and convert somebody who is who's, for example, transgender. With psychological societies, for example, because by not affirming somebody's gender, there's a massive increase, for example, in suicide. And so it's not considered ethical to try and do conversion on people who are transgender. So we need to create psychological services that are affirming. So the medical domain, which we'll talk about today, is obviously the hormones, using hormones to help people feel more comfortable within their bodies, talking about reproductive options, having trans-competent primary and preventative healthcare. And a big part of the guideline is making it possible that we within primary healthcare can create these affirming packages of care that has within it also prevention packages. Of course, gender affirming surgery also falls under that. In South Africa, still very little access to that. Voice and communication therapies, your speech therapists, your occupational therapists, and of course the guidelines, having actually guidelines that can guide the best possible care. And then there's also the whole legal framework. So this is, for example, having to go to Home Affairs and getting your name and your gender marker changed in your ID. And sometimes doctors are involved here and having to do a letter, for example, to confirm, still concerning that doctors have to make this decision, but that's still quite often legal requirements, and a lot around the advocacy and the legal rights and protection of people who are transgender. So when we are providing care to our transgender people, it's quite interesting because when I teach normal ARVs, when you teach your ARV guidelines, you just teach your guidelines and that's it. But when we're teaching about transgender care, quite often a whole lot of emotions come up. And there's no topic more laden with opinion than sex and gender. And I just want to recognize here that as our clinicians, as we're all sitting in this room, we all have our own cultural, religious, political perspectives on sex, sexual orientation, gender diversity. And those are very much determined by where you grew up, who your parents are, what kind of church you go to, what your culture is, and how you have sex and how you identify. So quite often what we know is also what we consider the most familiar. And all human beings have the bad habit of sort of assuming everybody else should be a little bit like us, and the less they are like us, the more suspicious we are about them. And I think it's just to emphasize its importance that the patients that come into our offices are quite often very different. And our goal with these guidelines is not to change people's personal views on sex or gender. A lot of these things are very much part of who you are and how you've grown up. And so therefore, I just want to be very clear that what we're bringing here is the family physician paradigm. It's our superpower as clinicians to be able to have and stand within our own ideas about sexuality or gender and still be able to be curious about diversity and to explore these differences and to be able to affirm and embrace differences and diversity rather than falling into that power trap we talked about earlier, and marginalizing those that are different from ourselves. And this for me is probably the most important thing, is that for those of us, because we have so much power as clinicians and so much power within that consulting room, to be mindful that our views does not take precedent over the views of another person, and to be respectful of that within our consulting rooms. So let's talk actually into the nitty-gritty of the hormone therapy part of it, because that's where we as doctors are often have a role and is one of the important focuses in these guidelines. And we're going to start off first talking about the informed consent process. So when we talk about hormone therapy, we have moved away from what we call gatekeeping to what we call an informed consent model. So in the past, there was this gatekeeping model and was very much based on a lot of fears. So there was this idea that hormone therapy is very dangerous, it's irreversible, clients are going to regret their decision possibly, maybe they're going to suffer these terrible side effects, and therefore it's my job as now the clinician, I must ensure that they're doing the correct thing and that we, and therefore the client or the patient almost had to prove their identity. And this set metric was created by cisgendered clinicians who would then have to sit and decide, well, are you trans enough to now actually qualify for hormone therapy? And you can see this is a bit of an ethical quagmire when trying to make decisions about hormone therapy. Where we're now looking at is we're using informed consent as the principle. And the idea is that we are empowering the individual, we are upholding their autonomy, and we're maintaining their integrity using our ethical principles. And we are actually just collaborative partners in this process. So you as healthcare provider are not taking responsibility for the decision-making. You inform, and you inform well, that is important, but the client decides what they want and how they want to do this. The focus is very much on the needs of the client. So there's different ways of doing it. You as a doctor doesn't decide how it's going to happen. And this informed consent is a continuous ongoing process, continually giving information, checking in where the client is and making sure they are continuously reaffirming their decision. And very important is we have to document these processes. There's always a huge amount of fear around regret. And I find that it's extraordinary. The statistics for regret in transgender is probably lower than in almost any other medical field, sitting somewhere between 1% and 5%. And most of your transgender people who do end up stopping their hormone therapy usually do it because of side effects or because of other issues, not usually because their identities change. But regardless of that, everybody's allowed to change their mind. And what we want to do is not therefore affect the 95% of people who find gender affirming care as a huge positive step in their lives. And I find it very useful for my patients to leave that door really open, to say, listen, everybody goes through different aspects of their lives. At any stage, you are welcome to also step out of this process, and that we also then don't end up victimizing people who decide to detransition at some stage in the future. So just as you healthcare workers, we need to make sure we've documented each part of these processes. We do like to have a team involved, and that trans and gender diverse person is part of that team. There's amazing support groups available on WhatsApp and on social media these days. Quite often you'll find trans people already part of huge support groups out there. We like to involve a psychologist or a counselor or a social worker, and that's not usually because mental health is an issue. It might be because of the society we live in, but because for transgender people, they have to navigate very complex societal aspects. When you're gay or when you're lesbian, you can quite often keep that part of your life private. But if you're trans, you're almost having to come out every single day in society in every aspect of your life. And you have to constantly deal with society's ideas and opinions. And having sort of a group around you that supports you is very helpful. So we like to have other parts, part of the MDT team might also then being involving sometimes an endocrinologist if needed. It's actually rarely needed. Hormone therapy is very simple. Sometimes we can involve surgeons, speech therapists, OTs. And then, of course, if we can get the family involved and having some support within the community, that is definitely a win. There is also an amazing set of guidelines specifically for our psychology professions on working with sexually and genderly diverse people. So the idea with informed consent is that all we need to do to start hormone therapy is the transgender client does not require a letter from a mental health practitioner. So you don't need a psychiatrist or psychologist to say this person should go on hormone therapy. As long as you are a GP that has got a little bit of experience, or you've got a bit of a support network around you, you've had a good informed consent conversation, then you can just be able to do that process and do that informed consent. You do need to do an informed consent form, and there's an excellent form. I've got couple of snapshots for that in a minute, in the guidelines. So in the back of the expanded gender affirming guideline, there's a complete informed consent form with everything you need to cover, as well as the part that the patient's going to sign, and then a whole part that goes home with them. For surgery, there's definitely more rules. Surgery at the moment has got a 20-year waiting list within the public sector, and there is mental health care. Professionals do get involved here. And again, it's not so much about them proving that the person is trans, but it's just to make sure that they have actually had more informed consent and really being able to understand the client's expectations and managing expectations. So let's get actually into the prescribing bit of it. The first thing is just to understand is that you're not giving gender affirming health hormone therapy as trying to validate this trans person's experience. It's literally just something that is helping them to with gender dysphoria and that gender incongruence that they are going to experience. And there's therefore not a strict roadmap. It's very individual on how different people will go through that process. They don't have to be dysphoric, so it's not a prerequisite to get hormone therapy. You do not need psychotherapy, and you don't need a counselor, and people with gender affirming health care, especially if they've got supportive families, do not have any mental health difficulties as part of being trans. And there's also no requirement that they should have lived in that particular gender for a particular point of time. Hormone therapy is safe, it's effective, and it is an essential part of the care for many of our transgender patients. And because there's a good evidence base for it, it's also now actually in our EMLs. The challenge is at the moment, it's only approved on the tertiary and quaternary levels. So we have it, for example, in East London, it's available at Frere Hospital, but it's not yet available in our primary healthcare clinics and secondary healthcare. There is a process ongoing at the moment, and part of the National Strategic Plan is specifically getting it into our EMLs. And you can see both estrogen and testosterone has been approved specifically for gender dysphoria as far back as December of 2019. If there are coexisting conditions, so if the person is depressed or does have other issues, we can manage those concurrently. You don't have to manage first the one before you manage the others. The indications, therefore, is very simple. Basically, a transgender person who comes in and says, I would like to go into hormone therapy is the only major requirement. They need to be transgender. They need to be somebody who has had this incongruence. And again, they don't necessarily have to have dysphoria. And they have to obviously be able to make an informed decision and be able to give consent to treatment. It's actually much easier than you think. I'm not expecting you all to go and be able to prescribe gender affirming healthcare, but for those of you that are interested to take it on, it's very easy to do. For family physicians, it should pretty much be if you're able to prescribe contraception and if you're able to prescribe HRT, for example, to postmenopausal women, and if you're able to give testosterone to men with low testosterone, then you already know pretty much everything you need to know. This is from the guideline, and just we're going to go through this, through all of these steps. It talks a little bit about your discussion you're going to have with your patient, what you're going to do for baseline assessment, which drugs are we going to use, and then how we monitor those patients. So in the discussion, and here's those screenshots that I mentioned. So there is an Appendix B and Appendix C of the guideline. There is some excellent, like a 3-page detail. And what you literally can do is you can just take it and just go through with it step by step. And there's certain things that we need to cover. So we obviously need to talk about the benefits and then potential risks. What you normally find is by the time transgender people has come and talking to you about hormone therapy is they have read extensively and probably know more about it than you do. And you just need to make sure that they've read the right information. We need to talk about reversibility. So what can be reversed and what can't. And frustratingly for our clients is most of the things are actually reversible, which is a frustration because they have to take the hormones for life to be able to actually keep those changes going. They need to be able to understand when things are going to happen and how long it's going to take and manage the expectations of what that's going to be like. So hormone therapy is not miraculous. If you come from a family of small breasts, then hormones are not suddenly going to give you large breasts. You will get what you genetically have as a baseline already. And probably the most important conversation is really talking through reproductive options. So that is the one thing that quite often is irreversible, that they might not be able to have genetically their own children eventually. Cryopreservation is an option for our rich, but having a very frank discussion about if there's not the option to have your own genetic children, adoption is an option, and being able to think through that as an option. So it's not that you can't have children, but you might not be able to have your own genetic offspring. So baseline assessment is very similar to what you will do when you do hormones like for contraception. So you want to just ask whether there's history of things like liver, kidney, cardiovascular disease, venous, your DVTs are always your worry, especially if there's estrogen-dependent malignancy in the history, if there's been a history of dyslipidemia, if there's been a history of diabetes. And none of this is contraindications, but it will give you a bit of an idea of things you might need to watch for. So you also then want to find out what's going on in the family history. Is there family histories of malignancies? Again, particularly the hormone-dependent malignancies. Is there family histories of DVT? And their own history of having surgery in the past and how they've managed those, and of course, allergies. Part of your baseline assessment is a physical examination, and very important that when we're dealing with transgender people, we have to have a trauma-orientated approach. And many of them are very dysphoric and has already had very unpleasant experiences, quite often from healthcare professionals, in how their bodies are treated. And therefore, we don't have to examine the breasts or the genitalia unless there's an indication. If you do so with consent, and be sensitive in terms of the language that they want to use. Then there's a nice little table that we can do for baseline bloods, and the guideline is very sensible. If you're in private, you might do the full blood count and the full LFT panel. If you're in a government section, you might just do an HB and creatinine and ALT. And very important is you don't have to do any hormone tests at baseline. And you can see this is all just to do with our usual risks that we would get with contraception as well. We obviously want to check for sexual things like HIV, hepatitis B, and syphilis. And if somebody's going to start testosterone, you want to have that pregnancy test. Because we are family physicians, we obviously want to look a little bit further than just all of this, all the medical stuff. Throughout our consultation, we want to be affirming and supporting our clients' decisions. We want to be screening for mental health conditions, particularly depression and anxiety. And again, it's not being transgender that makes you more vulnerable to having depression, but it's being transgender in the world we live in today. That means that a lot of our people have already experienced quite severe stigmatization and discrimination in their communities and are therefore more vulnerable. And similarly, also therefore at a much higher risk of substance abuse. Look for gender-based violence. There's a much higher incidence of gender-based violence in our transgender population, and have a trauma-sensitive approach whilst doing that. And we now need to ask about what's been happening with intimate relationships. And quite often one of the challenges for our transgender people is because of this gender dysphoria that might already have been a real challenge in the past. I've mentioned reproductive options before, but you really need to look into the dreams and hopes of this person and discuss family planning within that context. And look at the wider context. Ask how is the family managing it? Who knows? How are they presenting at work? What is the situation at work? What is it like in the church that they're at, in the area that they live in? These questions are important to ask to be able to help place our patient within their larger context. So I'm going to run through feminizing gender affirming hormone therapy, and then the masculinizing gender affirming hormone therapy. And again, this is the kind of thing that if you were to decide even, oh, I think I want to do this, as Path SA, we're very happy to provide some mentoring and somebody that can help, somebody you can call if you want to have some questions. And you can use the guideline to pretty much help guide you if you want to get started. If you're not somebody who's going to prescribe it yet, it's helpful to be aware of this so you can counsel your patient before you refer them to an appropriate facility. So feminizing gender affirming healthcare is for our transgender women. We want to induce feminization, and we have to suppress androgens. So testosterone is quite a powerful drug. And some of the principles is you want to use bioidentical hormones, so preferably estradiol above your Premarin and things like that. If we had the option, we would love to use the parenteral gender affirming healthcare rather than the oral. And the huge problem with the oral estradiol is that it goes through the liver, through that first pass metabolism. And therefore, to be able to get the amount of feminization that you would need, you unfortunately start going into quite risky dosages of the oral gender affirming health treatment. So quite often if you're using oral, you also have to give something that's going to suppress that testosterone. We will look at that in a minute. The parenteral gender affirming healthcare treatment is available very much in private, and there's a company called Fagrin, which actually is a compound pharmacy where you can get it at fairly affordable prices online. We don't tend to use progesterone, and there's not much evidence for progesterone. There's some work on micronized bioidentical progesterone, but usually we're just using the oral the gender affirming healthcare with that anti-androgens. The side effects is very similar to contraception. So they might get a bit of headache and nausea. We're always worried about the increased risk of DDT, but no worse than taking contraception. Mood changes might be an issue. And then with both, the way we phrase it is that there might be changes to the sexual response cycle and the libido. So testosterone very much drives sexual desire. And when we post all the links and the guidelines as part of this presentation, I will actually put in a link around specifically understanding the influence of testosterone and other hormones on how we experience intimacy. So we tend to all be quite obsessed with sexual desire and erections and testosterone types of desire. But actually, once the testosterone reduces, and even though sexual libido desire might reduce, there are other kinds of intimacy preferences that are oxytocin driven, which is also strong physical attraction, but is not necessarily sexual desire. And so these things need to be explained, that somebody doesn't think that they're losing something, but actually it's just something that's going to be shifting and changing. These are the preparations that we have available. So in our public sector, we should have Estrofem available, and that's our preferred medication. You can see we usually dose and then sort of increase over 2 to 4 weeks until we get to a maintenance dose. If you don't have Estrofem, you can use Premarin. So the conjugated equine estrogen also works actually fairly well and sometimes more available in some of our clinics. And again, we start with the low dosages and we slowly build it up. If you do have availability to the injectables, what's great about the injectables, it can be given IMI or subcutaneously. So we can train our patients, just like our diabetics, to actually give it themselves. And then in private as well, there's also a patch that is available. If you're going to use the oral estrogen, then you have to combine it with an anti-androgen. So if you are in private, you would use cyproterone acetate as a preference, but spironolactone works pretty well, and that's what we usually use in the public sector. Probably of all the things we prescribe, this is probably the one that is the most potential of side effects and that you got to watch because of that risk of hyperkalemia. So every time you increase the spironolactone dose, remember to check your potassium 2 to 4 weeks later. And again, usually about 50 milligrams of spironolactone does the trick. Can have some side effects, but those usually settle down. So this is the important little table. This is the table that you almost need to spend the most time with, and that your patient will probably be the most interested in as well. Because they want to know, they're using this feminizing treatment because they want to have a body that they're going to feel more comfortable in. And what actually happens is as you give it, the changes are not going to happen overnight. It's literally like going through puberty. So they will go through puberty where it's going to take several months to years to actually see these changes taking place. And you can see one of the challenges is that most of these changes are reversible. So one of the important changes is, for example, breast growth. It takes about 3 to 6 months before one starts to see even the breasts developing. And it can take up to 4 years to now finally have the breast size that you're going to end up with. And that is one of the changes that is not reversible. The other thing that's important to note is the voice change, and that's quite often a challenge for our transgender women because the voice box is actually already been changed by testosterone, and that can't be undone, that changes. And so we're not able to affect the voice with the estrogen. But what does happen is that the body fat distribution changes, one gets more of the waist and hips, the skin softens, there's a change in sexual desire I talked about earlier. There's decreased sperm production. This is not a guarantee, so they can potentially still be watch out that they can still be fertile. But they also start not losing less hair and growing less beard. And these again are not reversible. So once the treatment stops, all of these changes reverses. So now when we talk about masculinizing gender affirming healthcare, so this is for our transgender men, and now we want to promote virilization. And oral testosterone is not not suitable. And so sometimes we usually just give testosterone, and occasionally you might have to use, if the testosterone on its own is quite often enough to suppress the bleeding, for example, the monthly periods. But if that's not working, then we can use some of our inhibitors like leuprolide. But in our public sector setting, we would often use the Depo-Provera to just suppress the bleeding. But in the vast majority of our patients, testosterone will do the trick. So the risks and side effects that, so there's obviously some of the side effects that listed as amenorrhea, but that's obviously a side effect that is wanted. But acne is one of the irritating ones, and is one of the reasons why you might want to go quite slowly with introducing the testosterone. And basically what happens is transgender man, remember when for your cisgendered women who have their own natural estrogen, that estrogen before your menopause protects you against dyslipidemia and hypertension. And so if you now take that away and you give them testosterone, they're going to have the same risk of dyslipidemia and hypertension as the other men in their family. The only other thing to watch out for is polycythemia, but that's easy enough to manage through blood donation. So these are the two preparations we usually see, and it varies a bit on what you have available in your facility. So we used to have testosterone cypionate was the main one that was available in our public sector facilities, made by Pfizer, and then during COVID, Pfizer got distracted making vaccines. So for about 2 or 3 years, we didn't actually have testosterone cypionate. It's a little bit cheaper. You have to give it more often. It's an injection, but you can give it subcutaneously. So again, in private, a lot of our patients get taught on how to just give this injection themselves. But because of the stock out, a majority of our facilities now only have testosterone and deconite, Nebido, which is an intramuscular injection that has to be given every 10 to 12 weeks. And that's quite a little bit more expensive as well. The testosterone cypionate can also be ordered through our compound pharmacies as Fagrin, but I know it's back in the pharmacies, in the private pharmacies at the moment. And as it used to be it used to be available in public sector in the past, I'm hoping that they will again buy it again in the future. So this is the important little table in terms of masculinizing hormone therapy. And there's a few more things here that is not reversible. So the beard growth, again, it's also quite important to start growing the beard. It's one of the first things that makes a trans man also present as male. It takes about 6 to 12 months to start growing a little bit of a baby puberty beard. And again, it can take a good 4 to 5 years for that beard to come in completely. So one of it's both liked or not liked by different transgender men is the fact that they will get mold back pattern hair loss. And again, it'll be similar what's happening, your genetic predisposition. So if your uncles and your father tends to get bald early, then that will also happen. And that can happen within 6 to 12 months. And well, male pattern hair loss is quite not a very well known, it's not well described from our men in any case. And so it's not very well known in terms of how that continues. But you can see the other thing that also doesn't change is that the voice deepens. So for trans men taking testosterone, that does change the voice box. The voice will become lower. Also takes about 6 to 12 months. They literally also can have a voice breaking a bit like the puberty boys do. But that's also something that is not specifically reversible. But what will happen is that their menses will stop, but usually that does come back if they stop the testosterone, and other things like increased muscle mass and fat distribution will also change when they stop the treatment. So your laboratory investigations, we've mentioned there's those baseline ones that you will do. Then normally you will just check after 1 month, and you can see there's a nice little table in the guideline that tells you what you test for. And usually it's basically just checking your creatinines, especially in potassium if they're on spironolactone, and your HBs if they're on masculining treatment because of that polycythemia risk. And if they're on feminizing treatment, you might check the ALT, and it's 1 month, 3 monthly, and then annually thereafter. Just want to note, in private practice, you can, if you want, do treat to target with using estradiol or free testosterone. it's in the target you will be looking for. So you will put, so if they're transgender man, you will write man on your NHLS request form. And then after that, you will, when you get your results, you'll get the male values. So you're sort of heading for the male or the female values, depending on your patient. But in general, this is not particularly helpful. And what you more want to go over is the experience of your patient. How do they feel on this treatment? Are they happy with the changes and the pace in which the changes are happening? And in public sector, we will not do hormone therapy to monitor the treatment. So in what do we have in our settings and summaring? So for feminizing treatment, we would use estrofem, Premarin if you don't have estrofem with that spironolactone. And in masculinizing, we would either use the testosterone sapionate or the undeconate. I've just got a couple of slides on the non-medical affirming practices. And for a lot of our transgender people, especially at the moment, when you meet them, they've already gone through social transitions. So they are gender expressing with the identity that they're most comfortable with. And actually for the centuries, there's been lots of stories of people who have done that. James Barry is an interesting man who was, he was born in the late 1700s. Worked in the British Army, from Ireland originally, but he actually worked in South Africa for a while as a British doctor, and did the first cesarean section where the woman and the baby lived was performed by James Barry. And he was the second highest when he was in the military, and was the second highest medical person in the military when he died. And when he died in his 70s, they discovered that he had been assigned female at birth and had lived as a trans man his whole life. Many transgender people have a wish to pass and be able to pass as a cisgendered man. And it's mainly because in a society there is so little yet affirmation for transgender people. And so there's a lot of that we can do to help assist them with that. Gender, of course, is a social and cultural construct. What does it mean to be male, or what does it mean to be female? And so therefore you work very much with what the patient needs. And we can use our rehab teams. So occupational therapists can be very good in helping. And this is not rehab. It's about coaching our patients and helping them with what to wear, with putting on makeup, with doing their hair. And then our speech therapist, very, very helpful in helping them work on voice, posture, gesture, mannerisms, etc. So a lot of our transgender women will already be tucking. So arranging the penis and the testicles to present a flat pelvic area. And it's helpful to be able to be a little bit aware of tucking, or referring them to an occupational therapist. YouTube's actually very good in finding safe and comfortable ways of doing that. And they need to be able to do it quite easily. There's various tricks and tips, because otherwise you might have somebody who goes out and never goes to the loo the whole day because it's too awkward, too difficult and complicated. And that can cause problems in its own right. Padding, fairly easy. That's the use of prosthetics or padding to give the appearance of breasts. And for our transgender men, so packing, using prosthetics or padding under the clothes. The classic one in the books is always using the socks to give the appearance of a penis. But chest binding, very common in our transgender men. And that's a way to try and flatten the chest silhouette. So that's something that can potentially, sometimes if it's not done carefully and with the right, in the right manner, it can actually influence breathing. It can actually cause sores, and therefore being able to also advise and help and support that. There's lots of binders that can be used and can be safely used to help flatten that silhouette. So my last couple of slides is just in terms of how do we just start as a first step tomorrow within your facilities, how do we start creating gender affirming spaces? And this is not even to do with you actually being able to provide hormone therapy in your aspect. And as I've mentioned at the beginning, one of the many barriers for accessing healthcare for our people is the hostile and discriminatory behavior of healthcare workers. And therefore, training of our healthcare workers will massively contribute towards the improvement of healthcare access. And this is part of a key task in the National Strategic Plan training. And that's partly why we have this guideline and why I'm doing this session tonight. So one of the things I'll send round, for example, I've got this poster up in all our waiting rooms in CMH, for example, and that's just being able to give a message to our transgender clients: you're in a space where we are affirming and you are safe to be here. So this means already thinking in terms of your own reception and administration services. So we need to be able to get the correct name, the legal name, the pronouns, and the gender identity on the front of the folder. And that includes the electronic data systems that you use. For example, if you are in in a private practice. And the kind of thing we want to avoid is a scenario where a healthcare worker shouts out the wrong name or the wrong pronoun, wrong Mrs. or Mr. out over the waiting room. It can be absolutely mortifying, and that person will never come back. With billing information, for those of you in private practice, being able to be discreet with that and being able to keep that gender identity and treatment information obviously confidential and protected. Gender neutral bathrooms always causes extraordinary excitement. I'm not entirely sure why. One of the issues why gender neutral bathrooms is important is because of the vulnerability of our transgender people, certainly not the vulnerability of our cisgender people. In our settings, our staff loos are usually gender neutral. We normally have one staff bathroom, and so we've just put a gender neutral sign on that, and that was fairly easy to solve. Having gender neutral signage and having material that is inclusive of our transgender people. And so when you're sitting in the consulting room, we need to be able to train all our staff, and this includes the security guards. So they've been highlighted in that Retitsa report in terms of how they're communicating, but also our reception staff, our clinical staff, even our cleaners, to be aware of our transgender people and how to just be respectful in those spaces. Always ask for your clients' names and pronouns. If you get a pronoun wrong, it's not a train smash, just acknowledge the error, move on. And in that way, we can show that we are trying. Listen to the experiences of your transgender patients. Don't get hung up on the terminologies. If you get confused about what's non-binary and it doesn't matter. Ask your patient. They will explain to you what they want to be called and how they want the language to be used. And for us, when we're in the consulting room, to be very sensitive in how we take a sexual history, be very expensive about the terminology that people might want to use for their body parts, and very sensitive when we're doing physical exams. And just to have that trauma-informed response. You are probably dealing with people that has gone through some difficulties in the past. I'm not going to cover this last thing because I think we need to. I just gave a little picture of a transgender person in our consulting room. And the massive difference we can make just by affirming them for who they are when they are presenting. So my take-home message, please, let's educate ourselves, let's educate one another for this, be able to create a more inclusive society. And how can we create safe spaces at our healthcare facilities for all of our different key populations? And of course, tonight, specifically our transgender and gender diverse people. And then, of course, we would love to eventually have access to gender affirming healthcare for all our patients. Just become aware in your area, where is a gender affirming care happening? So at the moment, it's mostly still NGOs, but RHI, for example, has got 5 sites across the country. Aurum has got some sites, Beyond Zero has got some sites. So I think there's fairly good coverage in all the big cities. And just to be aware, we are slowly going to start building actually capacity within our district hospitals, within our primary healthcare clinics, to have the access to be able to access hormone therapy for those transgender people who wish to have it. Those are just some of my references and the major documents that we've used to put together this presentation. But I do want to particularly highlight that the South African HIV Clinician Society has an online training. It's a 6-hour training. The slides that I've presented today is an amalgamation out of that 6 hours. And so there's a huge thank you to Alma de Vries, Chris McLachlan, Anastasia Thompson, Ronald Adinal, Rutendo Botma, and Savuka Machila and Merchant Pillay for their contributions to helping make this slide set possible. And a huge thank you to the South African Academy of Family Physicians. We published an article last year in the journal on gender affirming healthcare, and that's partly also led to this presentation this evening, and gives us an opportunity to, as a continuing professional development for all our family physicians. Thank you very much. I hope we have a little bit of time for questions.